My name is Emily Weaver, and this presentation is on evidence-based practice regarding cardiac stress tests. In emergency healthcare, the risk of acute cardiac ischemia in the presence of symptoms such as chest pain and shortness of breath is a big concern. One test that is used often to determine the presence of ischemia once a troponin and electrocardiogram, or EKG, are negative is a cardiac stress test. This topic was chosen because there is much debate about whether cardiac stress tests are worth the time and the money they require. As stated by Mailer et al., there is a cost of $10 to $13 billion annually, yet less than 10% of these patients are ultimately diagnosed with acute coronary syndrome. Healthcare providers need to be good stewards of finances, but also need to ensure the safety of the patients they treat daily. The population of interest is adult patients with symptoms of acute coronary syndrome with negative EKGs and troponins. The intervention is giving a cardiac stress test, as opposed to the control group who does not receive a cardiac stress test. The anticipated outcome is that a myocardial infarction will be avoided, and the cost of the test is ultimately worth it. Therefore, the research question is, in adult patients with symptoms of acute coronary syndrome with negative EKG and troponin, does a cardiac stress test give enough information for the associated cost to avoid an MI compared to those who do not receive the test? In order to find articles for this project, a literature search was performed. First, I did a broad Google Scholar search with the term cardiac stress tests. This yielded about 2,200,000 results. I further narrowed down the search by switching search engines to the school library database. I used keywords such as cardiac stress test, myocardial ischemia, chest pain, and cost. Studies were determined relevant if they were published within 5 years, if they were peer-reviewed, and if they were able to find statistically significant information within the study. All the articles acknowledge that cardiac stress tests are only helpful in a very low number of situations. The one article that supports their use without concern for cost is Solanke et al., when they say stress tests serve as early detection of ischemia. Their article conveys the point that if the test helps even one individual discover cardiac ischemia, the test is helpful and worth the time and effort. The studies by Patanchetti et al. And Krishnan et al. Give information concluding that although the test is available and sometimes finds useful information, it is so inaccurate and reaps such a small amount of benefits that the test is actually overused. This is different than what Solanke et al. Found with regards to what is useful and what is not. The last two articles are similar in that they suggest that although stress tests are available to use, there may be a better way to use funding to allocate resources more responsibly. For example, Agus et al. Says cardiac CT scans have better outcomes and are more cost-effective, while Mahler et al. Says that low-risk patients do not require additional testing, and their study determined that it is a safe practice as they had no instance of adverse cardiac events in those without stress tests. Due to the information provided by Mailer et al., Krishnan et al., Patanchetti et al., and Agus et al., my practice recommendation would be to stop the use of cardiac stress tests on low-risk patients who have normal EKG and troponin tests. Cardiac stress tests should no longer be the gold standard. It has been shown that they not only are inaccurate in finding cardiac ischemia most of the time, but they do not yield helpful results in avoiding cardiac myocardial infarction. There are other tests such as cardiac CT or fractional flow reserve, known as FFR, that are more cost-effective and more accurate. One barrier to this change would be providers who are set in their old ways and are worried that they will miss a cardiac event if stress testing is not used. With education and thorough patient examination, these barriers can be broken. Cardiac stress tests are many times inaccurate. Between $10 and $13 billion are spent yearly on stress tests, and we need to find a more cost-effective alternative. New and better testing is becoming more available and affordable, such as cardiac CT, and FFR, and they can be more reliable results. Not all patients need a stress test. They are not as useful as they once were in the cardiac community.